This program is brought to you by Emory University.
Morning, everyone. It's a real pleasure for me to introduce our speaker today. Raj Dedhia has trained in medical school at Northwestern and in ear, nose, and throat, ENT otolaryngology at Pitt, and has been at Emory for more than a year, I think. At least that's how long I've known him. And he's been interested in sleep disorders, which is obviously something that we're concerned with and generally in our field tend to ignore, but is highly prevalent and has many cardiovascular consequences. So he's going to overview the role of sleep in cardiovascular disease and then some interesting new novel ways of treating this.
Thank you, Arshad. It really is an honor to be here. I have to lead with one of my dad's favorite jokes. It's very apropos, which is in the year 2040, the first Indian American president was elected in the White House. And at the inauguration, his mother was in the crowd, and she leaned over to the guest next to her and says, "You know, my other son, he's a cardiologist." So in our culture, you guys really are the tops. So it's an honor to be here talking to you guys about this topic. So it's cardiology and sleep apnea. There was a 3-day seminar in Prague in May, which was devoted to cardiology and sleep apnea. And I'm going to try to do this in the next 45 minutes or so to give you a glimpse of why this field is really neat and growing. So I don't need financial disclosures, but as you probably know, I'm not a cardiologist. And I'm a sleep physician and ENT surgeon. And like most academic talks, there's a bit of self-promotion here. And at the end, you'll see sort of my surgical bias, and just talking about treatments and surgical treatments for sleep apnea. So I just, if I give a talk to a group that I'm not familiar with, I just want to give you guys my background. I know when I'm in your shoes, I think about the same thing with the speaker. So I was born in Michigan, grew up in Pennsylvania, did my undergrad at Penn in the Wharton School in Healthcare Systems, moved to France to study the French health system. And then I came back and started medical school at Northwestern, matched at the University of Pennsylvania for ENT residency, and I met my wife on the interview trail, and then I transferred to Pittsburgh to finish residency to be with her. She's also an ENT here at CHOA. And then at Pittsburgh, I did a T32 research year, and part of that was doing a Master's of Science in Clinical Research with a focus on clinical trials. And during residency, I realized there was a real opportunity for otolaryngologists to do sleep medicine. So I was the 6th ENT ever to do a sleep medicine fellowship. I did that at the University of Washington in Seattle. And it was during fellowship I really learned how important cardiovascular disease is with sleep apnea. It really is what I talk to my patients about almost the most during the counseling session. So when I came here about a little over a year ago, as Dr. Kiyumi said, was to look at 50% of my time is protected with research, but to look at this question of sleep apnea and cardiovascular consequences. So I couldn't dream up a better practice that I have here. So I'm 2.5 days clinical. Monday mornings, I'm usually over at the Sleep Center in Executive Park, where I do a general sleep clinic, read sleep studies, help train the sleep fellows. Then Tuesdays, tomorrow is my all-day CPAP failure clinic. So patients who can't use CPAP, looking for other options. That's what I do almost entirely on Tuesdays. And Fridays is my operative day with some procedures, and the rest of the time is research. So I'm involved with training ENT residents, sleep medicine fellows, and that's really my schedule. So today, what I want to talk about is an overview of sleep apnea, the cardiovascular effects. I'm going to pick out 2 entities that are likely familiar to you in the audience, which is hypertension and arrhythmia. What is the effect of treatment on some of these outcomes? And finally, sort of this new treatment option for sleep apnea that we're excited about. So what is sleep apnea? So it looks like this, it sounds like this. Which is different from central sleep apnea, which sounds like this. So the first one was respiratory effort. You can tell that it was blocked by choking of the throat. That's obstructive sleep apnea. That's what we're going to talk about today. In this audience, central sleep apnea is pretty common, especially in the heart failure group, but we're not talking about that today. Today is just obstructive sleep apnea, so intermittent, repeated upper airway narrowing, or really just choking during sleep. It's fairly common in the general population. If you guys have been watching the World Series, Joe Buck spent some time talking about Mike Napoli, one of the Cleveland Indians players, who had severe sleep apnea, couldn't use CPAP, and he was sort of debilitating sleepiness, other issues with his play, was treated with jaw surgery and sort of changed his life. So we're seeing more awareness in the lay press and other people coming to asking us about it. What's really interesting is, what about sleep apnea in your clinics? There's one paper out of Brazil, Tertiary Care Center in Sao Paulo, which took 500 patients. They had 5 different clinics within cardiology, 5 clinics within cardiology, and took 500 patients, so 100 from each clinic. And they did a couple things, but one of the things was they actually took a sample of 10 from each of these clinics, and they tested them for sleep apnea. And they found the following. So the white bars represent patients who were diagnosed by a sleep study with sleep apnea. And if you look at the different, again, hypertension clinic, CAD clinic, arrhythmia clinic, heart failure clinic, valvular disease clinic, the white bars are between 50 and 80% of patients who have moderate to severe sleep apnea, random sampling in their clinic. It's incredibly high. And the shaded bar represents those who are sleepy. And I want to make a point here is that you don't have to be sleepy to have sleep apnea. Half our patients are not sleepy. They just have trouble sleeping. They feel like they have insomnia, but they're not falling asleep at the wheel sleepy. So yeah, we see that sleep apnea is in more than just those who are sleepy. And in the cardiology clinic, and one paper we have from last year, it's incredibly common. And this, the last bar, 0%, means that none of them had a diagnosis of sleep apnea. Now, I don't know if Brazil may not be as active in screening, but clearly there's a opportunity here to screen these people. So what makes people have sleep apnea? People always ask me in clinic, so why do I have sleep apnea? Was I born with it? Did I do something? It's a multitude of factors. Anatomy. I use an analogy with my patients of room and furniture. So this is a woman whose room is too small. She has a small mandible. So the room is small, that crowds the room, it crowds the airway. This is a young boy or man with big tonsils, so big palatine tonsils. So I say there's too much furniture in the room. So there's 2 ways why the room is crowded. The room is too small, there's too much furniture. But this anatomic crowding, we know, contributes to sleep apnea. But the funny thing about sleep apnea is most people don't obstruct when they're awake laying flat. It's when they fall asleep. So we know there's more than just anatomy. And I can give you plenty of examples of, for example, we test a lot of patients who are going for bariatric surgery, and they have BMIs in the 50s, 60s, 70s, and maybe 1 out of 5 have no sleep apnea. Or a young boy with 4+ tonsils has no sleep apnea. You think, well, he's so crowded, why is he not obstructing at night? Well, that's sort of what I call the black box. There's other contributors to sleep apnea that we can't readily measure like we can anatomy. To give you one example is pharyngeal tone. We know that those with sleep apnea have an excessive loss of tone during sleep. So the airway happens to just close down because they've lost that pharyngeal tone to keep it open. Again, we don't know why some people have it, but that's clearly a driver in sleep apnea. Obesity, airway edema, some really neat data looking at rostral fluid shifts. So venous pooling over the daytime with edematous ankles. When they sleep and you lay them flat, recumbent, you see actually an increase in neck circumference. And those who've got venous pooling, that's significant. So one of the treatments for these patients is putting on SCDs during the day to help equilibrate the fluid so it's not collecting and then shifting. So again, there's a lot we don't know, but my point is it's not just anatomy. There's a whole host of factors we're just learning about. How do you diagnose sleep apnea? So here I am doing my fellowship happily in a sleep lab. Most patients are not happy in a sleep lab because there's a lot on them. It's hard to sleep. But nonetheless, we can do in-lab polysomnograms. We also can do home sleep tests. Now, this has sort of revolutionized how we diagnose sleep apnea, home sleep tests. If you guys have seen this before, this is a watch pad. So a watch pad uses peripheral arterial tonometry in your finger to detect sleep apnea. It's pretty good in the right population. It's been validated. And again, this is it's not encumbering. You can fall asleep with just like wearing a watch on your finger, and you wake up in your own bed in the morning, come give the machine to us, and we can tell you if you have sleep apnea. And also grade the severity of sleep apnea. We grade it typically as mild, moderate, severe, as you see up here. So mild, less than 15, moderate, 15 to 30, severe over 30. And that's judged by the AHI. Well, what the heck is the AHI? That's the apnea-hypopnea index. How many times per hour are they having what I would say a complete or partial pause in breathing. An apnea is complete cessation for 10 seconds. Hypopnea is at least a 30% reduction for 10 seconds. These are generally accompanied, but not always, by drops in oxygen. We calculate that separately, called the ODI, or the Oxygen Desaturation Index, and that's how many times an hour does the O2 fall 4% from baseline. Again, that usually accompanies these events. This is sort of our metric of measuring sleep apnea. I can tell you it's far from perfect. Like maybe in your field or pulmonology, the 6-minute walk test doesn't correlate with PFTs. Similarly here, this test doesn't correlate that well with quality of life and subjective symptoms, but it's the best we have to quantify the disease. So who cares? Why do people come to us with sleep apnea? Well, they have daily problems. So this applies to mild, moderate, or severe apnea. They snore, which bothers their bed partners. They're often sleepy. They have headaches, and generally they just dread sleeping because they know that they're going to be up or they're not going to have very good sleep. Of course, this carries over into their workday with poor functioning and work deficits. And then what's really scary on the road or a public health concern is that they have a much higher risk of motor vehicle accident. Some studies 8, some studies 20-fold increased risk of motor vehicle accident. Because again, these people are the sleepy ones. But why am I here today? Well, because not just this daily problem or the function and quality of life issue, but this affects things that medical doctors care about: cardiovascular consequences, diabetes, obesity, cancer, even premature death. And this has been linked to moderate to severe sleep apnea, and that's really what I'm talking about today, which is moderate to severe apnea. And that slide that I showed you from Brazil, 50%, that was moderate to severe sleep apnea. So again, common, especially in this population that you guys take care of. How do we treat it? Well, most of you are probably familiar or heard of CPAP, continuous positive airway pressure. It's a pneumatic splint, so it stents open the palate, the tongue base, the entire upper airway. And it's so highly efficacious treatment, but as you can see, the different mask interfaces that we use to help patients use this every night, all night. Other options: oral appliance. Show of hands, how many of you guys have seen or heard of an oral appliance for sleep apnea? Okay, most, about half. So this is another treatment we use, which is like wearing a mouth guard at night, which takes the lower jaw and it does this. It pulls it forward. By pulling the lower jaw forward, advancing the mandible, you provide tension to the lateral walls and tension to the throat, what I call an airway stabilizer. That's one treatment, and we'll talk about a little bit today also. Finally is surgery. And traditionally, we had sort of 3 options. You had soft tissue surgery, removing the tonsils, or doing what I call pharyngoplasty to the throat. We can move the jaws forward, jaw surgery, or do a tracheostomy. But we've got another tool in the armamentarium, which I'll talk about today, which is neurostimulation. And this is called hypoglossal nerve stimulator implant. And again, I'll talk about this, but this is a different approach, and this is a different type of surgery. It's less morbid. They go home the same day. They're back to work in a few days. And we can do this, a brief anticoagulation hold, so hold Eliquis the morning of, and they're back on it the next day, which I could certainly not do with pharyngoplasty or jaw surgery. So it's really changed the population that we can treat with this new therapy. So in summary, the different treatments, you have CPAP, which I would say is the least risky, the most efficacious if one is going to use it, but because of poor compliance, it's not all that effective because the compliance rate is about 50% with this. Oral appliance, again, not very risky. In some patients it works great, in others not as consistent. And there's this out-of-pocket expense, as most dentists don't take insurance for that product. Surgery, by far the most risky. The results have been inconsistent up to this point, but generally speaking, once I operate on somebody, you can't take it back. So the compliance is excellent. But we'll talk about that surgery in a little bit too. Okay, so let's talk about cardiovascular effects of sleep apnea. I'm picking out 2, arrhythmia and hypertension, but as I'll show you, it affects a lot. Cardiac morphology. So we know that patients with sleep apnea often have higher pulmonary arterial pressures, which can lead to pulmonary hypertension. That causes remodeling of the right ventricle. That's been shown in several studies now. Cardiac function. So CPAP and heart failure improves systolic heart function. And we've seen now, sleep apnea worsens heart function and CPAP can improve it. So we see that there's a real role with cardiac function, sleep apnea, and CPAP. Heart rate variability, we're doing some research on this, which is a measure of autonomic instability or dysfunction. is impaired in those with sleep apnea, and CPAP can often reverse HRV changes. And I'll talk today about heart rhythm in particular. What about the blood vessels? So we measure arterial stiffness in Dr. Fumi's lab. So there's a clear impairment in arterial stiffness in those with sleep apnea. CPAP, in as short as 2 weeks, can reverse some of those changes. Blood pressure, again, I'll spend some time about today. And then if we do flow-mediated dilation in the lab, looking at brachial artery, we can see impairment in sleep apnea and then return to near baseline after 4 weeks of CPAP therapy. So sort of looking at the Bradford-Hill criteria of association and cause, we see how the biological plausibility and even the evidence that this sleep apnea affects these things and how it's often reversed with therapy like CPAP. So arrhythmia and sleep apnea really has a trilogy, and this is pretty robust now. 3 things that would cause these two to be so tied together. When I'm reading a sleep study, you'll see during the apneic period, patients often Brady down. Their heart rates go from 80 to 70 to 60. And at the end of the apneic event, when they kind of come to, we see a tachy response. So we think that vagal signature is that bradycardia. And so, and we know this too, that there is this shift during apneic spells, which is not so different from arrhythmogenesis, where there is a change in this sort of autonomic tone around the time of the triggering of the arrhythmia. Of course, sleep apnea, we see cyclical hypoxemia and hypercapnia. Hypercapnia can affect the pH of the blood. Conflicting data now with changing in pH and arrhythmogenesis, but we think the cyclical nature is, again, one of the common areas of these two diseases. And to me, what's sort of most fascinating, and I'm going to spend some time talking about this, is negative intrathoracic pressure swings and the effect on the heart. Again, when you're choking, you have a negative pressure. Your glottis is closed, and it's sort of this negative intrathoracic pressure that can get pretty intense, almost 100 centimeters of water pressure. And that affects the heart wall, heart chambers, and I'll show you kind of a neat animal example of that right now. This is a group that looked at pigs. They took 17 pigs, they trached them, and they gave them general anesthesia. And what they wanted to measure were different cardiovascular outcomes, measurements. They measured blood pressure by arterial line, oximetry, the atrial effective refractory period, and how likely or easily were they able to induce AFib. So each pig, after they were trached, underwent a 2-minute, almost like a finger occlusion of the tracheostomy. They were allowed to recover, and then they not just occluded them, but they applied about 100 centimeters of negative pressure to the trachea, again, to simulate what would happen as if they were having a sleep apneic event. And they found that the oxygen levels and the CO2 didn't differ between just the plain plugging versus the actual generating of negative pressure. But they found this. So on the y-axis, you have the atrial effective refractory period in milliseconds, and you have time lapse here. And again, this is the pressure on this axis, which is represented by this squaring off here. So when they apply this negative pressure at this point, you see this subsequent drop in the atrial effective refractory period. And when it's released, you see a return of the AERP. In the group that, when they just applied a sort of a cap over the trach without applying the negative pressure, there was very little change in the AERP. Even though the oxygen levels dropped, CO2 rose, but it seemed like that negative pressure was what was responsible for causing the arrhythmogenesis. And they found that only in the group that had the negative pressure were they able to readily induce atrial fibrillation. And when they did a vagotomy or gave atropine, that was prevented. In other words, there's an association here between that negative pressure, which then often tips off the sympathetic outflow, which causes the AFib. And if you can prevent it either by preventing negative pressure or by interrupting the sympathetic vagal output, then you could modify that response. The Sleep Heart Health Study is where we get a lot of our cardiovascular data for sleep apnea. Some of you may be familiar with the parent cohorts. These are 6 cohorts. They have over 6,000 patients. And basically this was a study where they drew from already existing cohorts to get some information about sleep apnea. They included patients over 40. They were a lot of minorities, and they wanted to oversample those with habitual snoring to try to increase the pretest probability of sleep apnea. And they had to have prevalent cardiovascular disease or hypertension. And they excluded those who were treated with sleep apnea. So the Sleep Heart Health Study has these types of patients in it, and I'll show you a couple pieces of data from these patients. They're 60 years old, half of women, mostly white, BMI around 29. Most of them were near normotensive, at least in office measurements, and then most of them were not sleepy. And in your cardiovascular population, we're seeing a lot of patients who are not sleepy but having sleep apnea. So here's a study which looks at a cross-sectional data of sleep apnea and arrhythmia prevalence from the Sleep Heart Health Study. So this study looks at several thousand patients, and they just looked across the board: AFib, complex ventricular entropy, non-sustained VTAC, bigeminy, quadrigeminy, and the shaded bars in gray are those with sleep apnea, and the white bars are those without. So AFib, the rate was almost 5% in the population versus 1% in those without sleep apnea. Again, out of this relatively older, sick cardiology population. Similarly, across the board, you can see the increased risk of those, increased association of those with sleep apnea and different types of arrhythmias. So it seems to be prevalent across the board. Now, this study looked at temporality. In other words, does sleep apnea, the event, trigger the arrhythmia during sleep? This is a pretty clever design. So they took now same group of patients, Sleep Heart Health patients, and they did a case crossover. Each patient served as their own control. So what they did was they identified an arrhythmia from the single lead EKG. And when they found the arrhythmia, they went back 90 seconds on what they call the hazard period. And they went back and they said, was there any sleep apnea during that period that preceded it? And then they found 3 other arrhythmias. They looked to see what was going on from a breathing standpoint before then. So the exposure here is a sleep apnea, and the event here is the arrhythmia. This is why it's a case-control type setup. Again, each patient was their own control. They ended up with over 60 sets of arrhythmia events. Again, they're trying to understand what is the effect of sleep apnea on generating an arrhythmia. And they looked at an odds ratio, and what they found was a paroxysmal AFib event was 18 times more likely to occur if the patient had preceding sleep apnea or sleep-disordered breathing. So from a temporality standpoint, it's a pretty good, almost causative study showing that if you have that triggering and sleep breathing problems and you have the substrate to have arrhythmia, it's likely going to happen after that event, as opposed to having normal breathing and then having the event. So again, some data on prevalence and also, I think, some causality in showing the temporal association between these two entities. For those electrophysiologists in the room or who are listening in, I know this is something that's talked about, which is AFib recurrence after PVI or some sort of catheter ablation. This is a meta-analysis of several studies, and they looked at sort of sleep apnea, whether they were diagnosed by questionnaire, which you can do, which is not nearly as specific as sleep apnea by sleep study. This is a forest plot showing the likelihood of AFib recurrence after catheter ablation. And if they had sleep apnea diagnosed by a sleep study, which is this, they were 40% more likely to have recurrence of AFib. So sleep apnea alone, again, this study didn't talk about treatment or not, but if you have a population of those with sleep apnea, there's a 40% higher risk of having recurrence of AFib after ablation or procedure. What about high blood pressure? Well, the apneic events are interesting because at the end of the apneic event, we see a sympathetic surge that leads to peripheral vasoconstriction. Also, that negative pressure is alleviated, and we take a deep, positive pressure breath, which, when after, it decreases LV afterload, which increases cardiac output. And by this simple formula, increasing resistance, increasing cardiac output, we see a bump in blood pressure. This is in work from Veer and Summers out of Mayo, which shows with an arterial line in place and looking at nasal flow. So this is the sleep apnea. You can see the airflow is attenuated, and then big breaths, attenuated, big breaths. And this is in the arterial line. You see the blood pressure neatly rises during these recovery breaths. Again, as the sympathetic outflow is increased, you see that, again, it matches all of these hyperpneic breaths. So just from an overnight, we see the timing of hypertension and the events. In sleep, our blood pressure is supposed to drop, and this allows us to recover or dip, especially in non-REM sleep. But in sleep apnea, we see this fall is blunted, or we call this non-dipping. This is a study from 15 years ago, which looks at this. So the y-axis, we have ambulatory blood pressure. The x-axis is time of day. Let's focus here during the night, between midnight and 7 a.m. So this is systolic blood pressure. This top curve represents those with sleep apnea, and you see it remains somewhat constant over the night. Whereas if you don't have sleep apnea, a clear drop at almost 10 millimeters of mercury during sleep. Diastolic pressure in sleep apnea, again, remains somewhat elevated. In controls, you see a neater drop. Now, there's emerging data that shows that maybe it's not the dipping, but actually the nocturnal hypertension that really is a better marker of this, but the same sort of variation on a theme is that they're not having that fall in blood pressure at night that they should be having. So there's a lot of data on this too. This comes from the Marin cohort of several thousand patients in Spain, mostly men, where they followed them for 15 years, and they looked to see whether they were to develop hypertension over that time. And this was not ambulatory blood pressure, but in-office pressures diagnosed as you have to have 3 with over 140/90 or on an antihypertensive. And if you follow these patients without sleep apnea or mild sleep apnea, they're down here. And then there's sort of dose response where the worse your sleep apnea is, the more likely you're to develop hypertension. And severe sleep apneics had over an 80% chance of developing hypertension over that follow-up time. Now there's a nuance here, which is sleep happens in different cycles. You guys may have heard of REM sleep, which I'll talk about in the next slide. But REM sleep apnea is getting more press in our literature. This is a study just this year out of Australia, which took 700 men, and they followed their blood pressure over time to see if there's an association between sleep apnea and high blood pressure. And they looked from a sleep study at their non-REM AHI, so not in REM sleep, but the non-REM sleep apnea was not associated with recent onset or prevalent hypertension. They looked at REM sleep alone, that's where the signal was. So if you had REM sleep apnea, there was an increased risk of hypertension, recent onset, and prevalent by more than double. So we're starting to understand that REM sleep is very important, not just for restorative nature for all of us, but also for those with sleep apnea and maybe predicting some of the cardiovascular morbidity. So REM is really a unique stage. It's the dream sleep. We think consolidates memory. There's increased sympathetic tone, and blood pressure typically doesn't drop during REM sleep. But what I bolded here is that it happens almost exclusively in the second half of the night. And apart from the eyes and the diaphragm, we're essentially paralyzed during that sleep. Some of the apps now looking at sleep cycle on your phone, use an accelerometer to determine if you're sleeping, because in REM sleep you don't move at all, you're almost completely still. But this is where you can imagine if your throat is sort of paralyzed, you're going to have likelihood of obstructing his way up. So sleep apnea is typically the worst in REM sleep. And there's more data showing that REM sleep apnea is important, or the primary driver of what I just showed you with hypertension, but insulin resistance, and even early death. So what is the effect of treating sleep apnea on some of these outcomes? So CPAP and Afib recurrence. Over 1,000 patients, this is a meta-analysis drawn from several studies. They looked to see if you use CPAP versus not use CPAP, is there a protection against recurrence of Afib? So they had, again, about 600 patients in the with sleep apnea without CPAP arm, 600 patients across all these studies that were using CPAP and had sleep apnea. And in sleep apnea patients, the use of CPAP reduced the risk of Afib recurrence by half, from 35% to 18% in this follow-up period. What about the effect of CPAP on systolic high blood pressure? So they took a meta-analysis here of 800 patients. These are all randomized controlled trials, typically with the hypertension as a primary endpoint. Follow-up was about 2 to 24 weeks. And again, across all these studies, 800 patients, they found that there was a mean reduction, or the point estimate here is systolic reduction by 2.5 millimeters of mercury. These are across normotensive and hypertensive patients. So a modest but prevalent, persistent signal across these studies. The same group looked at diastolic hypertension. Again, you see a reduction of 1.8 millimeters of mercury with those using CPAP with diastolic high blood pressure. So I had to mention this article today because this is something that's been talked about a lot in the last 2 months in the sleep world, which is what's the effect of CPAP on prevention of cardiovascular events and sleep apnea. Not sure how many of you have seen this article in the New England Journal a couple months ago, but there is a headline from CNN on the internet saying CPAP doesn't cut heart risk. That's really what it said, which is kind of tough. If you look at the nuance here, it's not quite clear, but let me just explain what this study showed. So this was a secondary prevention trial. So patients already had a TIA, stroke, MI, and the question was, if you put them on CPAP, could you prevent another type event? Over 2,000 patients. Most of these patients were drawn from Asia, primarily from China, which is the first time we've seen that. Moderate to severe sleep apnea, and they were overall not a sleepy group. I bold that because we are not sure what is the effect of CPAP on these non-sleepy patients. You can imagine it's easier to get a patient who's sleepy symptomatic to use a CPAP, but if they feel fine, doc, I feel fine, I don't know why I'm here, it's often harder to get that, to use it, and then also our data is not as compelling as far as the effect in these patients. The primary endpoint was death from cardiovascular cause or MI stroke, ACS, TIA, or heart failure admission. And they were randomized to either usual care or CPAP plus usual care. So the primary endpoint clearly showed no difference between the groups. Again, they were followed up for several years, and the CPAP group and the usual care group, the curves were almost identical. But one of the things that you'll see very cleanly if you read the paper is the mean CPAP use was 3.3 hours per night. So likely less than half of their sleep they're using the device. And that's a problem. And that's really what sort of led me to this second part of the talk today, which is the need for CPAP alternatives. 46 to 80% of patients with sleep apnea use CPAP for less than 4 hours a night. And there's very compelling data that hours of CPAP use correlate to how you feel and what your heart and other things do. And if you can imagine, if you're trying to use a CPAP at night, some of you in the room may use CPAP, may use it at the beginning of the night, but then you're most likely to take it off some point of the night. You don't remember. Often patients say, I don't remember, I just wake up and it's on my floor. Well, that means they used it for the first half of the night, but they didn't use it for the second half of the night. Why is that important? Because REM sleep goes unprotected. And that's what we're trying to really protect, is that REM sleep second half of the night. So I tell patients, whatever you use, it's got to be an all night, every night therapy, because otherwise we're really missing the boat. And there's limited data on CPAP alternatives in cardiovascular outcomes. I'm going to share with you just one piece of data in the oral appliance literature. So again, oral appliance moves the lower jaw forward, and that seems to stabilize the airway. So what's the effect of oral appliance therapy on hypertension, you might ask? So this is a meta-analysis of 400 patients, follow-up between 2 and 24 weeks. These are patients who are using an oral appliance with mild to moderate sleep apnea. Systolic reduction across studies. Again, most studies were observational, not randomized trials, so the data is not as strong, but a clear improvement in both systolic and diastolic reduction. As you remember from a couple slides ago, this is very comparable to CPAP therapy. So that's the only thing I can tell you guys today, is that these other alternatives, at least from the little that we know, seem to be, if they are working for sleep apnea, are also working for the cardiovascular disease. Last 10 minutes, I'm going to talk about a new sleep apnea treatment option. It's called hypoglossal nerve stimulation. This is a drawing here of how this works. So here you have an IPG in the upper right chest. There's a lead that gets tunneled down to the right intercostal space, 5th to 6th typically, and that sensor detects if you're breathing. So it's a piezoelectric sensor, sits over the parietal pleura, and it can tell if you're breathing in or breathing out based on the pressure changes. It then talks to the IPG, and the IPG then is tunneled up. We have a lead in the neck, which stimulates the 12th cranial nerve, which, as you'll see, moves the tongue forward. Thought this was sort of neat because in this room, you guys are familiar with cardiac stimulators, and this technology was spun off of Medtronic. This is Inspire that I'm talking about. And there was a group for neuromodulation at Medtronic, and they wanted to see if there was some application in sleep apnea. And then this group called Inspire, again, an independent organization, started developing this technology. And you'll see some similarities. So for Inspire, there's an IPG, there are leads, there's a programmer, patient has control. In the pacemaker and defibrillator world, similar IPGs, different lead types. There's a programmer interface, and there can be some remote access. This therapy that I'm going to talk about has a little remote that has about a 5-centimeter radius, so you put the remote over the device and you turn it on and off at night. That's how patients control it. There's a sensing algorithm. So the Inspire sensor, again, detects the change in intrathoracic pressure from breathing in and breathing out, and then it's only on at night, and it's only on during the phase of the respiration when you're most likely to obstruct. So let me walk you through a flow curve. So this is a inspiration, expiration, inspiratory pause, inspiration, expiration. And the blue marks when the therapy is on, and the green when it's off. And so you see here, the therapy is on when you inspire, because when you obstruct, typically it sounds like this. You breathe out, and then you're trying to breathe in, you can't. The airway closes. So we need to make sure that we cover that vulnerable part of the cycle, so it's timed to do that. In the cardiac world, of course, with pacing, similar. It's using some algorithm to detect, and then often, of course, firing when it's needed in the cycle. This implant is done typically under general anesthesia. It takes me about 2.5 hours to do the surgery. There's some risks of tongue soreness, tongue abrasion, low risk of infection. They go home the same day. I said most patients who are on anticoagulation, we can hold it if it's something like Eliquis for a day or so before and start them back the next day. They're back to work in a couple days. This battery lasts about 10 years, so they have to come back for a battery replacement in about 10 years. The current generation is not MRI compatible, hoping the next one in 5 years will be. So here's the surgery itself. So there's 3 incisions. This is patient's jawline, collarbone. So you see one underneath the jawline on the right side, upper chest, and then lower chest. We dissect out the nerve that, again, stimulates the tongue, which is called the hypoglossal nerve. Intraoperatively, we have EMGs in the tongue, so we can tell when we stimulate this nerve before we put the cuff on, if we're stimulating the nerves that move the tongue out or pull it back in. Of course, we don't want to pull the tongue back in, we want to pull it out. So we're pretty specific and sophisticated in how we can stimulate intraoperatively to make sure that we're getting the nerve branches that move the tongue out. And so you see here, this is a tripolar cuff that we put around the hypoglossal nerve, and it's anchored by that. So at the end of the case, we want to test the device. And this is where everybody huddles around the patient's mouth to look to see what is the tongue doing when we stimulate. So this is not very subtle. You'll see with stimulation in this video what happens. The tongue comes straight out of the mouth. It's being pulled forward by stimulation. Try that again. So again, we're testing intraoperatively. We're stimulating that nerve and looking at what happens to the tongue with stimulation. So we want a bilateral protrusion out of the mouth that portends the most likely chance of opening the airway. So they come back at 1 week for a post-operative wound check. At 1 month, they come back, turn the device on. So it's not on when they leave the OR, but a month later. And they come back at 2 months to titrate the sleep study to make sure that, like a CPAP, we get the right voltage. So like a CPAP, we adjust centimeters of water pressure. Here we're adjusting voltage. And that's how we can determine what's required to open the airway. So here's an endoscopy. I know most of you haven't looked at the airway like this before, but this is what I do, looking at the airway from the inside, because what matters is what's happening to the throat. Is it staying open? This is a patient of mine we're doing in my clinic. She's awake, she's laying flat, and we're looking at the soft palate and the tongue base to look at what's the effect with stimulation. So you'll see here, I'll pause it to show you where we're looking at. So this is the back of the soft palate, this is the back of the throat, and the black represents the airway. And again, we want this to be open. This is with her awake, so we want to see what's the effect, again, just with stimulation. So stimulation on, you can see the palate moving forward, the sidewalls opening up, stimulation turning off. When we go down with the scope to the tongue base, these are the 2 most common types of obstruction, the palate and tongue base. And you'll see down here there's the airway, stimulation coming on, so the throat opens from the side, opens from the front. We get a global opening of the airway. on that one more time so you can see the soft palate opening up and then the tongue base. So again, here we are at the top of the soft palate. We're looking to see what happens from the AP and also the lateral dimension of the throat. So with therapy on, it's providing tension to those walls and opening it up from back to front and side to side. Going down to the tongue base, again, the second most common side of obstruction. We want to see a similar mechanism or effect when therapy's on. It should open up that tongue base also. Therapy on. I'm sorry? One more. Oh, yeah, thank you. Yeah, thanks for asking that. So this, what I call a Pringle potato chip here. And so that's epiglottis, is an opening to the voice box. And by moving the tongue forward, we often yoke the epiglottis with it, which is very important. And you'll see here, epiglottis seems to move forward also in this patient. So I'm going to end with some of the data on this therapy. This comes from the New England Journal 2 years ago, which is the STAR trial, Stimulation Therapy for Apnea Reduction. Multi-center, multinational trial, prospective, 126 adult patients with moderate to severe sleep apnea who couldn't use CPAP. Again, it's very clear. What I'm talking about today are for patients who cannot use CPAP. The mean BMI was 28. They all had undergone surgical implant. And then they took a random subset of 46 patients and they put them in either withdrawal, took therapy off for a month, or kept therapy going, and then retested them to see was there a return to baseline if you took therapy away for a month. So you look at the median AHI, we went from 29 down to 9. The ODI went from 25 to 7. So we essentially put them in the mild or normal range, which is our goal here. For cardiovascular outcomes, we want that AHI less than 15. We think that's what's protective against the increased risk from sleep apnea. So again, a 2/3 reduction in AHI and similar in ODI. And about 2/3 of patients responded to this therapy. When we look at subjective outcomes like sleepiness and function, for sleepiness, the group was normalized, and the same thing for functions of sleep. Their ability to function was also normalized. So really exciting data for how they perform and how they do with therapy. Again, half these patients then were randomized to either, of the 46 patients were randomized to keeping therapy going or taking it off for a month. So the group in blue is the therapy maintenance group. Their baseline AHI is 31. When they were on therapy, it was 7. And when they, again, a month later, when they checked them, it was more or less the same at 9. In the group that had the withdrawal, they started off at 30. They had a good response to 7. But when they took therapy off for a month, they came back to the near baseline. So we're pretty clear, like CPAP, when you take the therapy off, the effect is lost. And again, one of the neat things about this procedure is that you can treat it like a medical device where I could take it back. Can't take back jaw surgery or soft tissue surgery. Certainly this is like a medical device you can sort of switch on and off. So who qualifies in today's world? There's pretty strict criteria by the FDA. Patients have to have a BMI less than 32. Their AHI has to be between 20 and 65, with less than a quarter being against central events. This does not treat central sleep apnea. Central sleep apnea is a problem where the brain is not telling you to breathe. This stimulator of the throat will not help that problem. So it's really for obstructive sleep apnea. And then you cannot have a certain type of collapse pattern on the sleep endoscopy also. So there are limitations like anything else. A third of patients from that study did not have success. So I tell patients 2/3 chance of success. A third will require what I call adjunctive therapies, whether that's an oral appliance or having them sleep on their side, or something else in addition to just the stimulator. This IPG can is not MRI compatible. Again, for the next generation in 5 years, we suspect that it will be. It's a long process. So if you don't have Medicare, so Medicare by law has to follow FDA guidelines, but every other commercial payer does not have to. So one of the troubles, frustrating parts of my practice is that if you have a commercial carrier, this can be a 3, 4, 5, 6 month process to get approved. Typically it does, but that's a long process for both me and the patient. So there's that upfront part, but after therapy, it's 2 months to get the device titrated and then working. So it's not a come in my office, the next day we get it sleep apnea fixed. This is a long process. It requires compliance. So unlike other surgery, which is sort of one and done, you have to take the remote control by your nightstand and turn it on, and then in the morning, turn it off. So there's some compliance here. The STAR trial had a compliance of 90%, so most people are using it if they have it. And then dry mouth is common. Sometimes by moving the tongue forward, you can open the mouth, which can cause dry mouth. So I can warn patients about those effects. So is there any data on nerve stimulator and cardiovascular information? There's not. I'm going to share my own experience with Angel Leon and I shared a patient with severe sleep apnea and paroxysmal AFib. So this is a 50-year-old guy I saw about a year ago, was looking at treatment options, could not use CPAP. He had been seen outside for a trach. He, an otherwise young, fairly healthy guy, said, I don't want a trach. So we evaluated him for the nerve stimulator. He was a good candidate by most metrics. So he had the surgery in February, and we had put in a Medtronic Link loop recorder in shortly after his surgery, but before we activated, because we were thinking, wouldn't it be neat to look at AFib burden before therapy and after therapy? And he had the AFib, he had the loop recorder implanted, and we measured his AFib burden from the download. Pre-activation was about 9%, and then when we turned and we checked it just last month, when now therapy has been on for several months, it was 0%. Now, there's a clear confounder here, which is he was started on an antiarrhythmic in April, so I'm by no means attributing the entire effect to the sleep apnea control, but it probably had some role in this. But the point is we don't have any data on this, and that's sort of how I'm trying to hopefully make my initial research career, which is looking at cardiovascular outcomes in this new therapy. Again, this is a whole new way to treat sleep apnea. We don't really know what it does. When you stimulate the throat, is there an effect on sympathetic outflow from a brainstem reflex? We just don't know. So I'm looking at patients who've had a nerve stimulator with me at Emory. We're doing different outcomes. So we have a peripheral arterial tonometer in the sleep lab, which can detect, it's a proxy for sympathetic outflow. We're doing ambulatory blood pressure, FMD, arterial stiffness, and serum biomarkers in Dr. Kumi's lab. We're going to get measurements at 3 points. So before therapy is activated, once they're on therapy, and then after they're withdrawn for a month. So we kind of look for a similar pattern. Is there this effect with therapy on that's then diminished or returned to baseline with therapy off? Again, this therapy allows you to do that kind of thing where you can take it on and off. So in summary, I hope I've imparted that sleep apnea, moderate to severe, is really common in your populations. Sleep apnea has profound effects on the heart and blood vessel function. CPAP treatment is first-line therapy. It's got the least risk, the most data, so we really try to push CPAP on patients. But the truth is half of patients will not use CPAP long-term, and we can't just let them go by the wayside. And there are alternatives now that are emerging, like oral appliance therapy, nerve stimulation, that really patients should be evaluated for these therapies. Knowledge of Sleep Center, it's a great clinical collaboration, and also the research power has really been fantastic for me, starting off at Emory. Dr. Kumi, who's been a very strong research mentor, and Dr. Leon, who's been helping on the clinical side with patients, getting things going. Thanks.
Thanks, Raj. That's really interesting. You're going to help us out here. Okay, we'll see if we have any online questions. I'll start off with a couple of questions. So, I guess two questions. One is you indicated about a third of the patients don't seem to respond, and any ideas of how to risk stratify that better going forward? And then second, the other complication I was thinking would be potentially a problem. Explain to me why it's not is aspiration at night, because a lot of these people have a lot of my sleep apnea patients also have pretty significant reflux symptoms in the evening, etc.
Thanks for your question. The first question, a third of patients who don't respond. It's sort of like the holy grail in the field is figuring out, can we stratify a priori who's going to respond, who's not going to respond. That data that I showed with the STAR trial was 2 years old. We think we're a little better than that, maybe 80% are going to respond, but we still don't have an answer as to why they don't. We do all due diligence, we do the sleep endoscopy, identify the anatomy, but where they fail is when the tongue moves forward, which almost they all have great tongue motion. We rely on the soft palate to be coupled and move forward with it. We're not directly stimulating the soft palate. So that palato-glossal or palato-tongue coupling is where we fall down. And we don't have a good way to, again, determine that beforehand, but hopefully soon. Aspiration. So similar, this therapy, again, is on at night only, and it's on during the inspiratory phase of respiration. So there could be a similar concern with things like oral appliance where the airway's open and could they be aspirating. We haven't seen aspiration or GERD worsen, at least I can tell you anecdotally from these patients. And I don't think I have a good, my explanation to patients is when you're having these negative pressure events, we think that's what really pulls the acid out of the stomach, out of the esophagus, spills over the arytenoids and into the larynx. And this idea of the nerve stimulator is to prevent that negative pressure buildup. So it's sort of like a prophylactic measure of doing that. So I think most patients have an improvement in that sort of field because, again, we're sort of, I think, taking it from the nidus of that negative pressure development.
Some other questions? We use the microphones here. And anybody remotely, you can type them in there.
I have a lot of patients in my clinic who are intolerant to CPAP. If we just refer them for a sleep center clinic visit, will they be evaluated for some of the alternative treatments?
So my clinic at Midtown on Tuesdays, for example, is a CPAP alternatives clinic. So if a patient has had a previous sleep study, is not using CPAP, I would see them. We can get in touch directly with me, and I can see them to look for alternatives, so they can sort of bypass the sleep center route if they've already tried CPAP. And I usually talk to them. If some people haven't tried CPAP in years, and CPAP has changed a lot, and I usually will try to have them try it again if they're willing, and if not, we'll go to the other therapies.
On the non-dippers, percentage of non-dippers that have sleep apnea, what is that? Is it 100%?
I cannot give you a number. I know it's common, but I don't have data on. I don't know the data on how common it is.
And because they carry a worse non-dippers carry a worse prognosis than other people, and I just wondered if that was reflecting something. The other thing I can't quite follow on you is when you move. I can understand the paroxysms of hypertension when they have apnea. But how does that move to the chronic stage of hypertension? What happens there that makes it chronically elevated?
Yeah, my understanding, again, people in the room can feel free to welcome their input. Like with pulmonary hypertension, we see vascular remodeling. Vascular remodeling changes from the persistent hypoxemia and hypercapnia. So over time, we see changes in the vessels at that level, which we think is the chronic substrate. So not just, like you said, the paroxysmals of hypertension, but over time, the vessels themselves from the hypoxemia and hypercapnia seem to have changes.
Bob probably knows more than you. Do you know?
Yeah,
Bob?
I think you've got the current hypothesis.
So does that work by moving the tongue where the mouth is open or closed?
Correct. Yeah, and
When the mouth is closed, then the tongue moving forward within the mouth works.
So the tongue is a hydrostat. So if the mouth is closed, it seems to still be able to fill the volume of the mouth. So about half my patients sleep with their mouth closed with this, but half of them will maybe reflexively open the jaw to allow for the tongue to move forward. And one of the questions people ask is, do they wake up? That was a pretty robust movement in the OR. It's typically not so strong, but some patients have to acclimate because they'll feel the stimulation the first month or two, and then over time we just start them low and gradually ramp up, and then most of my patients now have been able to acclimate over the course of several months.
So there have been reports of cardiac pacing devices and potentially having an impact on sleep apnea. I think that literature has been somewhat indefinite, but I wanted to see what your thoughts were. And then also the pacemaker and defibrillator companies are trying to develop sensor technology, either based on heart rate variability or a variety of things, as well as respiratory muscle movement to help detect sleep apnea. And I was just interested in your thought about that. And then finally, how do we get that guy Jimmy off the air on XM radio? If anybody listens to XM radio, it's Jimmy from ZPA here, and just some comment about what is that technology that he's talking about.
Sure. So unfortunately, I'm going to have very unsatisfying answers to most of your questions. The first question you asked, and I've been told by another cardiologist, was that the pacing, I think it's a case report or case series, where they're looking at pacing or defibrillating with sleep apnea, and that there is an improvement when you pace them. And I need to find that study and look it up. I don't know if they're talking about central sleep apnea or obstructive sleep apnea. Do you know more about that data?
Well, there was a paper in the New England Journal in like 2002 of
Okay.
like 15 patients or something. I was surprised that it made it in the New England, but yeah.
Yeah, so
And it was both central and obstructive.
okay, yeah, again, I'm not familiar with that. This idea of using sensing algorithms that's really exciting. I think the Inspire folks and again the Medtronic folks are very well known to each other about how to integrate a device like you're saying, where you could sense with that pacemaker, or even, we implant on the right side of the chest. It's really to leave the left open for cardiac hardware. I'm doing a woman next week. We're going to do the left side because she has a port on the right side. We can do it on the left, but we like to keep that open. So, people have talked about having both pacemakers and having a common wiring, but I think that's further out. But yeah, this idea of even what more can we put into that hardware for sensing is something that's interesting too for the Inspire world. And then Zipa is a type of mouth appliance. So the mouth appliance, again, works by moving your lower jaw forward. I would caution you in saying that if you buy something online, these usually boil in bites, where you buy something, it's a thermoplastic splint, you put it in water, you bite down, and that becomes your now oral appliance, are not nearly as effective as going to a proper sleep dentist and getting it done. So the Zipa, I have patients come in, like you said, this guy Jimmy seems to really tout that, and then they usually haven't had a good response, and I say, well, let's just back up and let's try it the proper way, because again, these things, if they work, great, but they shouldn't then discourage somebody from saying, oh, it didn't work for me, it's not for me, because these are by no means professional grade. Yeah.
Okay, well, Raj, thanks so much. That was really great. Thanks so much for taking your time to join us today.
Yeah.
The preceding program is copyrighted by Emory University.